On this week's episode of the Post Call Podcast, we're going to talk about cardiologists treating a non-cardiology disease and which drug is helping them do that and should they be doing that and who's going to do what. We're also going to talk about CBD, what physicians need to know, what patients think they know, and we're going to hear from the person who wrote the article. Dr. Elisabeth Poorman is our guest this week and someone I've been trying to have on for a long time. Dr. Emmy Okamoto joins me as always, and we were 13 hours apart. However, due to a snafu, we found out that Cambodia does not observe daylight savings time. So now we're a simple 12 hours apart.
Yes, that snafu is called daylight savings time. Gosh, is America the only country that does that, right? And only part of America, not only the whole thing.
Indiana and Arizona don't. So get this, those two states switch time zones.
That's so goofy.
Yes, everybody hates it, except for in Indiana. Indiana's one of those states that has like a border where it's a different time zone in the same state, which I thought it was too small for that. My brother went to Notre Dame, which is how I know this. So you can go backwards in time in Indiana by going to one county and then to another. So on a road trip, you'll gain an hour and then lose an hour. It's the weirdest thing. It's not acceptable.
That's real trippy. Not good for tourism and being on time.
No. Yeah. Real bad. Okay, so we want to start this week with a study published in JAMA Internal Medicine, Association of Workplace Sales Ban on Sugar-Sweetened Beverages with Employee Consumption of Sugar-Sweetened Beverages and Health. The article is published by Medscape. The journal article is published by JAMA Internal Medicine. And what happened is a college, University of California, San Francisco, obviously, banned sugary drinks, and they found that it was sort of effective in some ways.
Yeah, it's interesting because we see these all the time at, city and county and I don't think we've seen it at state levels, but we've seen national levels in Mexico for taxes, and everyone's like, oh, but you can just go to you can just drive outside the city, but this is just a workplace. It's a very small change here, and yet we're still seeing a big effect. So it went from 35 ounces of sweetened beverage to 17 after the ban.
Which is reasonable to me. I always thought, I worked in a liquor store for a while, and I thought that all liquids that are just drinks for fun, alcohol or otherwise, everything is sold at too high proportions. 12 ounces of like a really high ABV beer or wine is a lot to me. So 18 ounces is still a lot. That's more than a can of soda.
Yeah, it was surprising. But you think of, they weren't only counting sodas, they were counting your bottled teas and coffees that look healthier, but really just have a lot of sugar as well. But the other thing I will note is they noted when they tied it to education that was a much more drastic change. So those who got education cut down 25 ounces a day. We're only 8 ounces a day if you just saw the sales ban without education.
Right. So you talk about why they're doing it and like, hey, we're not just trying to run your life, but this is why and this is how bad it can be. That was a pretty big number, statistically significant. And I think this is something you're going to start seeing. I don't know if everybody's seen the documentary Fed Up. It was really popular on Netflix for a while, where during the Obama administration, lobbyists for sugar companies kind of made things about being active and not about sugar. But I think that the book is starting to come out in popular culture, and I think you're going to see more of these bans. That's just my guess.
Yeah. Very interesting.
So I want to talk about cardiologists and diabetes. So for a long time, we've been covering it here at MDedge for years. SGLT2 inhibitors, we know about what they do for diabetes. It has come out recently that they are essentially like miracle drugs in a way for heart failure. Now that means that cardiologists are going to be using these drugs as therapy for patients with heart failure, but does that mean that cardiologists should also be kind of making the decisions for type 2 diabetes? This comes from Medscape. By the numbers, cardiologists are well positioned for diabetes care.
Yeah, and it really goes into, there's a ton of cardiologists out in the United States, and there are not so many endocrinologists, and I see this when I have my patients who I'm trying to get into endocrinology for very out of control diabetes. And the wait list is 6 months, but gosh, what can happen in 6 months? every 6 months is their visit. So, primary care takes a lot of the burden, but we also know how intimately it's tied to heart disease and cardiology. And cardiologists are trained in internal medicine and are smart people who as well know about the A1C, the basics of diabetes care, which thankfully isn't that challenging, but so important for general health and cardiovascular health. And as you said, a lot of the drugs are overlapping and do have cardiovascular effects.
Which is it's one of those fortunate things that I don't think a lot of people saw coming that can make a big difference. But I think when I read things like this, what I see is not who should be doing what, but that there should be someone who kind of has all of the information. And my main takeaway here is that whoever is the primary internist or the family care physician should know everything that's going on, because my general sense is that there's an opportunity for overlap or for things to kind of fall to the turf here.
And I think what this highlights, not is all of a sudden that cardiology should start taking over diabetes care, but that we need to think about how we can integrate better, that we need to start having these discussions of will, cardiologists start prescribing these meds, and how does that look like, and how can we foster communication, ideally using a better medical record system or something, so that we can make this better for patients, because it's an opportunity that's presenting itself ultimately.
Yeah, I completely agree. And I think that these drugs are going to be in the mainstream for a long time, the SGLT2 inhibitors. So this is going to be something that we're going to start to see a lot of as well. Okay, so something that you and I got into, one of our last articles here, more clinicians say human first labels are preferred. This is a poll, and you start to think of how to address patients with what, and we're talking about diseases that maybe in popular culture or in healthcare have been used as descriptive terms or modifiers to pronouns. And if you're not a word person, this can all get very nerdy. But the idea is how to address physicians. For example, how do you feel about calling someone an addict? 60% of physicians, 73% of nurses are APRNs, and 86% of physicians in psychiatry and mental health found that term problematic. So that's an example of this poll. I think this is really interesting because I'm a huge word nerd. And addressing people is, I don't like the term microaggression, but it's something that happens kind of in the rearview mirror or in the subconscious that really impacts just the way we view each other.
Yeah. And I did like they did interview a nurse who was like, hey, listen, I get that it's not correct to say diabetic, but I have, 20 minutes to give a report, or just 30 minutes to give a report on 32 patients. So if I have to say a person living with diabetes, it takes me so much longer than just saying diabetic and getting the words out. So I get it. I see where a lot of it comes from. But is that correct? The other thing is the obese. Oh my gosh, it took me by surprise because I have said obese patient as just a descriptive adjective, and apparently that was one where the younger generation found it less problematic to say obese patient than the older generation, who is actually more, as we had said, woke with a person with obesity.
Right, exactly.
Because it's a disease. Yeah. But it's also an adjective like tall or short. So to me, that was hard to think about.
Exactly. I also think that the nurse who was interviewed, we'll give her proper credit in the show notes, or him or her. And the thing that is important to understand is that I think that there are contexts where what you're risking by not doing it properly is different. So taking a note, or when you're trying to write a report, I think and this is how it was explained to me by an editor and a mentor in this business, which was by calling someone a thing and using their disease as self, what you're doing is assigning chief complaint or their primary disease, which is scientifically dangerous. So if you call someone a diabetic, you say this is the most important thing about them. And if someone has diabetes and cancer and rheumatoid arthritis, you as the writer or the person using the word, you can't do that. And if you're in a clinical setting, it can be really risky to do that because you can confuse people. As an editor or writer in media or whatever, it's just incorrect and not my place to assign chief complaint. But in a clinical setting, it can be dangerous if a patient has multiple things going on for someone to just assign chief complaint. And even though like as a clinician, not to think of it that way, it can just subconsciously click in your brain, and that's how the English language works, and that's how people get confused. Also, fun fact from a nerd, that's how people get so offended in like political arguments and stuff, is you assign identity based on an adjective instead of saying it's like person of race versus race person. And that's why people get mad, because you get defensive of that. So calling someone a diabetic is not only like insensitive, it can really confuse you clinically, subconsciously, because that's how English works.
Yeah, and no one likes to be labeled. You're right. No one wants to be called that. No one wants to be known by just their disease.
Right. I am not my disease. I am not my race. I am a Venn diagram of an infinite complexity.
Yes, we all are. That makes for a long, chief complaint first sentence, but we will get there.
Yes. And so the poll, again, really interesting to see what people thought of it. Like I said, the disparity really tripped me up. You were talking about how the obesity numbers, where people by a different age who work in healthcare use it differently, or I guess we're more woke, as you made the joke. But like 29% for diabetic, that's really low. Neurotic was up to 70. I think that was the best one. So it was a really interesting poll, and you can find a link to it in the show notes. And our final topic, a topic we've covered a couple times on this show, cannabidiol, aka CBD, available at your local gas station, and what it is and what physicians need to know about it, and how to talk to patients about it. We've talked to Dr. Tussonian, Shani Dio. She talked about it. She has blog posts about it. And our guest this week, Dr. Elisabeth Poorman, just wrote a piece at MDedge Internal Medicine talking about the exact same thing. So what would you say to patients asking you about CBD for their joints and their overall health?
In general, it's kind of the same thing. It's like, well, we have some data that there may be some minimal, but tangible benefit. There may be some harms. Placebo effect is real. We can give it a try. But I really like this article because it really kind of went through in a step-by-step. I've thought a lot about the benefits, but I think it really highlights the four main harms. I thought was really good to lay out, particularly a lot of the stuff that patients are buying and is being sold. It's not regulated. We don't know what's in it. There's, heavy metals. Some have THC where it says it just has CBD. So really have to be careful here.
Yeah, I agree. The thing that really bothers me the most is that people with platform who are not scientists are kind of pushing this thing. And what you hear in discussions about this is people will say, it's always an anecdote. It worked miracles for my aunt. It worked. My mother swears by it, et cetera, et cetera. And that's obviously anecdotal data. And if it works for them, it works for them. We've had oncologists on different podcasts say, I don't really tell my patients yes or no. If it works for them and they want to do it, whatever.
Yeah.
And I think that's the most important thing, because there's the misinformation is so strong. I think Shani called it literal snake oil. It's CBD oil. It's literally BS. It's being sold as this miracle thing. Like, well, it works for my knee. Like, it might. Your brain also really might want something to work, and that you bought this thing and here you go.
Yeah. Which I don't know.
Again, that's working for you.
Yeah.
Right?
As long as it's not too expensive or harmful, which it could be both. So let's take a look at Dr. Poorman. She is our guest this week. She was someone I've been trying to get on for a long time. We kept going back and forth, and also 3 time zones apart, which honestly, our situation is actually better than 3 or 4 time zones apart, because that's really hard to coordinate at what time of day. When you're just on the other side, you can just say, someone's got to be in the morning and someone's got to be at night. Yep.
She works in Seattle. She really likes to talk about how to talk to patients and how the whole healthcare system can evolve. And she works on things like burnout and just communication. She's one of the better interviews we've had in a long time. And did you get a chance to listen? I think I sent this to you. We have had this in the camp for a while.
Yeah. I really liked it. And I've heard her speak before, and I think she has a very grounded position of, what it's come to mean to her to be a physician in primary care and what's important, how to connect with the patients. And I think she thinks a lot about that, writes a lot about that, and I think uses her writing to connect in a more deeper way with the people who she treats.
Which is really cool. The way she does it, it's very artistic. It's there's a lot of emotion to it. It's pretty deep. Her website says that she's bridging the gap between the public and how doctors think, and that's so important because as she talked about in the interview, and it's so obvious that someone can think that if a doctor says this, that's just a fact, and you find out that it's a lot more like, a quarterback calling an audible or a writer waking up one day and just on a whim writing a novel. It's not as well coordinated as artificial intelligence or data in, data out. Practicing medicine is a lot more artistic, and I think that she's trying to, communicate that to the general public, which I think is really important.
Yep. And she's very active on Twitter and fun. Lots of good things coming up.
100%. She does a lot of cool stuff on Twitter. You can find her Twitter and links to all of her stuff, including her website and her academic profile, in the show notes. Coming up in a couple of weeks, we're going to talk about Elizabeth Warren's healthcare plan. I don't think I'm important enough to endorse anyone, but we are going to talk about it because healthcare is talking about it. A specialist taking pay cuts and Medicare for all, $20 billion, presidential election. We're not going to get that deep into it. We are going to address it because she's the only one that has come out with a detailed plan, and that's what this show is all about. Also got Dr. Ashley Alker. She consults in Hollywood to make sure that medicine is accurately portrayed on screen. And I don't know if you saw this on Twitter, The Blacklist by NBC made a huge boo-boo. I will share it with you. Huge, like laugh out loud boo-boo. Everyone, all of the doctors on Twitter were like, oh no, oh no. So that's coming up later this month. And Emmy, I think everyone wants an update on how your cat is doing, the one with the broken leg.
Oh yeah, I have a cat with a broken leg who is still limping, but she's able to jump onto the bed, which is unfortunate for me in the morning. Yeah.
Yes, natural alarm clocks. They are always much better than the artificial ones. So what do you got going on lately in Cambodia?
Not much. Yeah, she jumps up on the bed. She tries to get through my mosquito net because I sleep under one of those. And recently, I was sewing up all the holes she caused with her claws. That's my life.
So that's what your life is going to be, chasing after her. Coming up next, my interview with Dr. Elisabeth Poorman. Emmy, thanks so much for hanging out, and we'll be back next time with the Post Call Podcast.
Good to be here, Nick. Thanks.
Welcome back to the Post Call Podcast. I am your host, Nick Andrews, and I am joined by someone I have been going back and forth with for quite some time, and someone that we really want to talk to, Dr. Elisabeth Poorman. And Dr. Elisabeth, you are on the west coast of Seattle. I'm here in Philly. The sun is setting, as you can see behind me, but you've got the whole afternoon in front of you. So how are things up there? And I hope that the air quality is not doing too bad. You got a lot of bad fires in that region. I was just over there.
It's actually a beautiful day today. I'm actually at the ACP conference learning about headaches before I got on the phone.
Yeah. So what did you learn today?
It's interesting. I think I really like the ACP conferences because they're very practical and practically oriented. And it's less about, kind of like the latest and greatest and more about what are the finer points of the data and how to communicate it to patients. Sure. So I was particularly interested in how to talk to patients about medication overuse headache. So that's people who are taking medications, more than a couple of days a week and actually making the headache worse. And I find that that's a very difficult patient population to treat because they feel better when they're taking the medication, right?
Yep.
So that's like a lot of things in medicine. Deep prescribing, I think, is one of our hardest but most rewarding jobs.
Sure, absolutely. And I also think that we live in a very right now society, so there should be a pill for everything. I should get it on Amazon and it works right away, and there it is, and everything works well. And sometimes that's not the case.
Yeah, I think that in general is what I find difficult about the American mindset about health is. People are always looking for shortcuts.
Sure.
So to that And earlier we were talking about the microbiome, and the idea that, if you have chronically poor diet, chronically bad lifestyle, then your microbiome suffers. And so then the response is to try to create probiotics, for which there's very little good data and may actually be some harm involved. So I think, just like, or, the idea that you can take a multivitamin instead of eating well. So I think over and over again, we just see that you can't actually mimic lifestyle choices with the medication, which is what we're trying to do.
Yeah, no, of course. So I started my career in oncology writing, and then made the transition to MDedge and Frontline, and that's now owned and operated by WebMD and Medscape. And as I got into family practice and internal medicine, what I found is diet and exercise and going to sleep and not smoking and not drinking are a lot of things that people have a problem with. That's day one stuff, right?
Absolutely, yeah.
All right. So you mentioned that you want to help talk to patients about stuff, and that's one of the things why we wanted to get you on the show. I'm looking at your website right now. You're bridging the gap between the public and how doctors think. And your website, which is drpoorman.org, is very artistic, and you've got these selected writings, and it's like kind of think piecey essays about getting people from the thing that's ailing them as a patient to how you are going about not only analyzing, your years of experience, the data sets in your brain, but then also putting together the human side of having treated this person for a while. So tell me what the website's about, and tell me what you're trying to do with these writings, and then also your appearances in popular media.
I think I'm very concerned about the eroding trust between physicians and patients, which, it's lovely that has been quantified over and over and over again to show that patients are increasingly mistrustful of the things that we say. But I think, in the lived experience of it is very difficult as a physician. There's an idea that we go into medicine for money and status, which I certainly hope not, because it's a really poor decision if that's the reasoning behind it. I think, people, perhaps some people kind of initially have that thought, and I think most of them end up in investment banking.
Yep.
But no knock on investment bankers, but, I think a lot of people go into medicine because they want to help people. And then you experience the reality of training, and you experience the reality of an increasingly perverse healthcare system, that it is profit driven, and it is extremely exploitative of providers and patients. So, first in the writing, dealing with, issues like alcohol addiction or opioid addiction, or whether or not to take an aspirin. I try to bring people into the process of how to understand the data, because I think when you can kind of walk people through your thought process, then there's a lot more trust of what you're saying, and that they're more likely to kind of internalize the message. And actually, one of the greatest compliments I got. My dad has been going to this butcher in our hometown for many, many years, and really excellent place. And one of the butchers said to him that she really loves my writing because she feels like it's complex scientific issues, and that she can actually follow it. And I think there's a fetishization in medical writing. And medicine in general, and certainly in the kind of things that we fund and promote, to think that the more esoteric and difficult to understand something is, the more sophisticated it is, the more important it is. And to me, these broad issues that affect so many of us are really much more interesting and much more impactful. So I'm really just trying to, kind of help people understand, how their physicians are thinking through these complex problems. Why we, I think it drives people crazy. We try not to say things with any certainty because we don't have certainty. So how do we think about, when a physician says, I think this most likely is going to help you. I can't 100% say anything, right? But this is the best decision we have with the data right now, and trying to help people understand that thinking process.
Yeah, and it's really highbrow. It can get highbrow and philosophical, but then like the communication part of it to me seems to be very simplistic. Like in my opinion, as a philosophy and history nerd, I think that, you know, with the Enlightenment and all this, we've become a scientifically based society, which is very liberating from a religious based society in a lot of ways. But one way I think it's dangerous is that it reduces humans to data points. And so it is logical for someone to suspect, well, the doctor said this is a fact. And now that I've been covering medicine, I realize that your training is scientific, but your practice and your application is artistic. It's individual, and you're like a quarterback calling an audible or a painter waking up and deciding to do something different that day. It is not textbook pathology. It's all making different decisions. So when a patient gets confused, like I Googled it, this is what it should be. Like, yes, but not always. This is not a law. This is something that we got to figure out together.
Right. Yeah. I mean, with all the guidelines in science are on populations, and every day in front of us are individuals. So that's the gap.
Yeah, 100%. So we're looking at some of your writings, and you've got responses from readers, and you mentioned some of the compliments that you've gotten. But what's the future for writing and bridging that gap? And how do you think that you've done, and how do you measure success on bridging the gap between patients and how they communicate and how doctors think?
You know, I think certainly, like every other writer, I can be very vain about how many people have actually read something I've done, and that's really nice and flattering. But much more important to me are when people email me and say, you know, you changed my mind. That's the best. Or, you know, you've described an experience that I thought I was the only one that had, and I, you know, appreciate that. So, you know, that's kind of for me how I measure success. And then, you know, also, understanding something more deeply. So it's certainly like a selfish enterprise, in that, you know, I want to serve my patients better. I want to understand their questions better and how to respond to them better. So recently I did a couple of articles about marijuana, including one about CBD for MDedge. And that really grew from patients asking me a lot of questions about marijuana, you know, being in a state that has legalized recreational use, about, you know, whether these claims of medical benefit or concerns about harm, like how to actually evaluate it, how to be, you know, a wary consumer. And, you know, there's no teaching in medicine about that, but that's a very real concern for a lot of my patients. So it really allowed me to just have dedicated time and a deadline to really wrap my head around that.
Yeah, I think, well, that's a great example of one topic that's in pop culture, and that people are, I guess, in popular media. When I say popular, not what's popular, but in mainstream consumer-oriented media. But this seems like, to me, and maybe this is just me being a millennial and hyperbolizing, but it seems like people have never been more health and medically conscious of themselves and of society than they are right now. And I see a lot of things that make me think that it's a good awakening, and then other things like relationships and trust with doctors that make me think this is more challenging even than it used to be. For the example I use is, on one hand, I can't fathom the logic for not vaccinating one's children or not vaccinating oneself. On the other hand, if the logic is the doctors are corrupt and trying to make money, we just went through the opioid thing. So it is a hot button issue right now. Like CBD, opioids, vaccinations, obesity, all of these different things taking place. I think this message is very important. Do you feel extra pressure for that? And how do you feel that the way that medicine and health are portrayed in pop culture?
I mean, I think in general, a lot of terrible things have happened, and, you know, particularly to the millennial generation. You know, I know it's, I guess I'm an elder millennial, as they say, but I think, you know, it's quite fashionable to, you know, say millennials have ruined everything. But, you know, you look at my patients who are millennials, or, you know, general population, people are working 13, 14 hours a day. Even our leisure time has been commodified, and we're, you know, literally turning ourselves into brands, and, you know, using even our social time to kind of promote our work. So I'm very concerned about the, long-term implications of using every single working hour to try to be productive, particularly when there's no kind of economic security, even for, the very wealthy. Like, you see what they're doing with their kids. They're, basically professionalizing childhood and, making these kids, like I had a young girl the other day, 18, 19 years old. And I asked her, how school was going, and she burst into tears, just discussing the stress of it, trying to finish high school. And I don't understand exactly like why we've all decided to, kind of torture each other to death this way. So I think the kind of obsession with health and, medicine and, self-medication is because our lifestyles are making us incredibly sick, and we don't know how to stop that. We feel powerless to stop that, to even take a break, put our phones down. So I think that's kind of where it comes from. And then, simultaneously, I think there is a very real and valid concern about institutions, including healthcare institutions, like not being on the side of the patient, right? I mean, every time you go to a physician, you get, or, NP or PA, you get a bill, and then you might get 7 more bills for the rest of the year. And a lot of that has to do with the absolute dysfunction of American healthcare system that, as a nation, we've had complete lack of courage to respond to. And a lot of that has to do also with, venture capital entering healthcare and trying to make more and more money. So I think, people kind of, they are feeling all of these pressures. They don't know who to trust. And so it certainly erodes the doctor-patient relationship. So I think like that's all very understandable. And yet I think, what gives me hope is that almost everyone I know who went into medicine, particularly into primary care, and I will just, share my bias here, really wants to help. Yeah, really wants to help their patients, and for the most part puts up with, difficult and often toxic work environments to try to do the best thing for their patients. So I hope to kind of help strengthen those relationships a little bit if I can, and also just to support people who are trying to do good work in the face of a lot of things that set us up for failure.
Yeah, and that seems to be the really difficult part, is that it's the only quote unquote system that I know of that kind of doesn't really work for anyone. I hear the pharmaceutical companies have to price gouge to make a profit. Patients are paying so much money. Doctors are worked to death. It's suicide and burnout are out of control. So no one is benefiting. It seems like there are some companies here or there that are turning a big profit, but it's kind of this thing that we're all in. We're like, oh my God, this is awful. And everybody's like, yes, I know it's awful. It's awful for all of us. So, I mean, without trying to address the system, you're doing your part by just trying to improve this communication, as we mentioned. How do you think it's gone since you've started, and what's next?
It's been good for me. And I think it's also been, good in that, when I'm interacting with patients in my professional life, there's a power differential, but, as a writer, that differential is more or less gone. So people can respond to my writing or my social media, as people who've had individual experiences with physicians that kind of help me understand different viewpoints, or more what it's like to be on the other side receiving advice. So I take it back to like, as long as I'm learning, I'm happy, and I'm, I think like it's successful. In terms of like, the larger questions, I think I'm sort of at a crossroads trying to figure out how much of that to engage with, because I see, it's not really my area of expertise right now, but I see As I said, more and more venture capital coming into healthcare, prices going up and up. I mean, my patients can't afford insulin, for God's sakes, and it's 100-year-old medication, right? And there have been pretty much no improvements in insulin in the last 10, 15 years that I'm aware of that justify this price increase. So, on the one hand, like, do you do the most good by just trying to work within this like increasingly broken system, or is it time to try to help people fight for something better than this? So that's kind of where I'm at right now.
Yeah, no, that's it's such a difficult question, and I mean, like, the solutions is because so many people seem to think that like going to a different model makes a ton of sense, but even that you're like, well, this is like a 50-year process, and I mean, it's very intimidating. But like for the day in and day out in the clinic, it's just so difficult to keep having these conversations. But I want to switch gears a little bit. Let's talk about who you are. So I'm looking at your profile right here. You are board certified in internal medicine, and you're at, I believe the kids call it UW in Seattle. Is that right?
So I'm told. Yeah.
Yes.
I know. I called it UW, and I was promptly corrected.
Yes. You were. I think they call it Dogs Plain. They have one of the top 5 mascots. All of them are tied with all the other dogs. All of Tennessee's got a dog, and A&M's got a dog. They're all the same level of cuteness. But so you're in Seattle at the University of Washington, board certified in internal medicine. You write for MDedge, and you write for yourself, and you do a bunch of other things. So how'd you pick your specialty? Where'd you go to high school? Where'd you go to college? Where'd you go to med school?
So I'm from Illinois. I grew up in a suburb of Chicago and graduated from New Trier High School, and went to Harvard College, and where I studied history of science.
Nice. That's so cool.
Yeah. And did a lot of work on the history of leprosy, and worked in some leprosy colonies in Brazil for a couple of years after college. Then went to medical school at Emory, where I also got a public health degree. And Emory is a really interesting place because it has that huge county hospital, Grady, which does amazing work, chronically underfunded, but just really some really incredible clinicians. But you also see just like the absolute terror of what we do to people living in poverty and people who are living undocumented. And then meanwhile, you have very well-funded, really interesting scientific work being done at Emory. But I always found that going back and forth between those hospital systems always gave me a lot of whiplash, and didn't seem to bother other people in the same way. So that was hard, and that's always been tough for me, is how differently we treat people based on their ability to pay. Yeah. Meanwhile, you're learning like everybody is the same and do no harm, and that you're not supposed to treat people differently, and that's not how we're practicing. But I chose a residency, Cambridge Health Alliance, that's at a small community hospital in Cambridge, Massachusetts. It's part of Harvard Medical School, but it is actually a state hospital, and with a huge immigrant population. They're Portuguese and Spanish speaking mostly, but also Haitian. And I chose that hospital because it was one of the few places that I had been where none of the residents said anything negative about patients while I was visiting.
Interesting.
And I was really concerned. And I saw in residents across the country, and my friends who had finished a year before I did, I saw a massive decline in empathy, and that was one of the things that worried me the most about medical training. So that's why I chose Cambridge Health Alliance, and I was very happy that I did. And then worked there for a couple of years, and I'm now, I fell in love with an Amazon employee, so now I got stuck in Seattle.
Yes. Well, maybe Virginia one of these days. No?
Oh, yeah, perhaps. So I'm told, yeah.
Yeah, those are the rumors. Well, so now you're there, and you guys are working for UW and Amazon, which are two low-key companies in Seattle that some of us have heard of. and you seem like your profile says that you enjoy hiking, the outdoors, and music, which to me seems like we all enjoy those things. But how much of an outdoorsman are you? And it's really, for those of you who've never visited the Pacific Northwest, and going to a meeting in Seattle doesn't count. I'm talking like Coeur d'Alene and Seattle and Tacoma and Pullman and anywhere in those areas. It's really low key, beautiful. So tell us what you do for fun, and what you do in Seattle.
Yeah, so I really do like hiking, and I like the outdoors, but I think increasingly what I'm understanding about the outdoors is that it involves a lot of planning.
Yes.
And I would not call myself a planner. As anyone who has had the misfortune of camping with me probably has experienced. So I really love, doing like 4 or 5, 6 hour hikes, and then, coming back. Or I had a group of friends that I camped with in the New England area who are all former Boy Scout leaders. So they had all the gear.
They got you. Nice.
And I was taken care of.
Nah, that's good. Those are the people I try to surround myself with when I'm out of my element. Like, hey, I will do whatever you say, but I'm not here for thinking.
Yeah, exactly. That's this is my off time. Yeah. I don't want an Excel spreadsheet of pancakes.
No screens, please. Yeah, sure. So that's really cool. I haven't been back there in a long time. Like I said, I was just in San Francisco, but that's really cool. So what is on the table for you in the next 2 years, 5 years, 10 years, both clinically as a scientist and clinician, and then outside of that extracurricularly or outside of that personally?
Well, I'm really hoping that, as a nation broadly, and I think, sort of what's been underreported and misunderstood is that enthusiasm for single payer broadly is up, and then particularly for clinicians in practice, it's now over 50% would be in favor of single payer. I think, any healthcare system, any innovation, we bring, our existing problems into it, right? So it would be, I think, anything is going to be a painful transition. But I think inertia and lack of action is really not an option. When you think about, more and more primary care doctors going into direct primary care, which I totally understand, but meaning that they're inaccessible for the majority of the patient population, or leaving practice altogether, or, just, becoming administrators and just having less and less access for patients. I don't think that that's an option. And then, meanwhile, everything is becoming more and more expensive. So I think, all the problems that we have are about to accelerate. So I'm hoping that as a country, we have the courage to try to do something better for everybody. But I'm not sure.
Yeah,
I'm not sure. But I would like to be a part of trying. So I guess that's it's a kind of a philosophical answer to what you're saying. But I'm trying to figure out how to be part of that.
It's a mark of a good scientist, asking questions instead of having a definitive answer. I really like that. I will say this. I heard it on a podcast that somebody was laying out options, and I forgot what he said. He was an author and a PhD and an MD, and it wasn't single payer. It was something similar to single payer, and I forgot to bookmark the podcast. I got to go back and find that. But that guy really explained something to me that I had never thought about, and I'm in favor of both of those. But this other one, I got to spread the word. We'll have to have that guy on. But I really appreciate you coming on. And nudge, if you could tell your significant other that if we could get something like Epic that is run by Amazon, or that looks as easy and as awesome as Amazon, that'd be neat. No pressure. Just something that is out there on Reddit and Twitter. Wink, wink. No?
That you want an Epic system that's more efficient, basically?
So that's what, yeah. If I had to pick something to improve about the EHR, just making it better would be a good start.
Yeah, well, let me put it this way though. Like, I think the right now the incentives are broken, right? Mm. So the incentives are to maximize profit and patient satisfaction, but not necessarily minimize morbidity and mortality.
Sure.
And the clearest example of that is we pay women less, even though we have better outcomes, right? And I worry about companies like Amazon and others entering the healthcare market I do think that they're going to accelerate all of the problems that exist, because any innovation with broken incentives just cracks it open more and more and faster.
Yeah, like the any financial crisis or any sort of breakdown of economics, you can open a textbook basically to any century in history for sure. Glad we agree. I think that you've given us a lot to unpack here, and I think we're going to have you on down the road and maybe talk about a piece that you write specifically. I really enjoyed it, and I thank you. You and I have been going back and forth for what feels like years, and we nailed it down and we got it done.
I appreciate your patience.
I appreciate yours. That's Dr. Elisabeth Poorman. This is the Post Call Podcast. Dr. Poorman, I really appreciate it. Thank you again.
Thank you.